Hello students, welcome to this session where we are going to cover sarcoidosis part 2. In part 1, we discussed the epidemiology, etiopathogenesis, clinical features and differential diagnosis of sarcoidosis. In this session, we are going to cover the diagnostic criteria, the investigations and the treatment of sarcoidosis. In 2009, an international workshop was organized to set up diagnostic criteria for sarcoidosis. This was actually revised in 2017 and it describes 7 clinical signs and 8 investigations after other causes of granulomatous uveitis has been ruled out. Now let us look at the clinical signs first. I think we have gone through most of it in part 1, but you need to have a bilateral involvement, whether clinical or subclinical. Mutton fat keratic precipitates and or iris nodules, which can be copious nodules located in the pupillary margin, or you can have Busaka nodules in the iris stroma. In the trabecular meshwork, you need to look for nodules or 10-shaped peripheral anterior synechiae. Coming to the posterior segment findings suggestive of sarcoidosis, you look for snowballs or string of pearls in the vitreous. In the choroid, you have to look for multiple chorioretinal lesions in the periphery, whether they are active or inactive. Vasculitis, which is nodular or segmental, and sometimes you have this candle wax drippings, or macroaneurysms in an inflamed eye. And finally, look for optic nerve granulomas or isolated choroidal granuloma or nodule. Among the investigations which are useful in sarcoidosis, you have imaging modalities and you have other investigations. Well, you know that the lung is the commonest site of involvement in sarcoidosis. So in all these cases, you're going to do a chest X-ray or a CT scan looking for bilateral hilar lymphadenopathy, or they should have parenchymal lung changes, which is suggestive of sarcoidosis, as decided by pulmonologist or radiologist. The other 2 imaging modalities which may be useful are the gallium-67 scintigraphy or 18F fluorodeoxyglucose PET scanning, which will show abnormal accumulation of dye in areas of inflammation. Coming to the set of other tests which are useful in sarcoidosis, what I would like you to remember is that 2 of them are negative and 3 of them are positive, or rather it is increased. So you can have a negative Mando test or interferon gamma releasing assay, and you can have a reduced lymphocyte count, less than 1,000 cells, is suggestive of sarcoidosis. On the other hand, if you get increased serum angiotensin converting enzyme, so you can have an elevated serum lysozyme or an elevated CD4-CD8 ratio more than 3.5 in the bronchioalveolar lavage fluid. So depending on the presence of ocular signs and investigations with biopsy, you can classify ocular sarcoidosis into definite, presumed and probable. So to have a definitive diagnosis, you have to have a positive biopsy to demonstrate non-caseating granulomas. So you have a positive ocular sign and a positive biopsy, it is a definitive case of sarcoidosis. The other tests may or may not be positive. Now, if you have 2 ocular signs positive and you have bilateral hilar lymphadenopathy, even in the absence of biopsy or investigation results, you can say it's a presumed ocular sarcoidosis. If you have 3 ocular signs which are suggestive of sarcoidosis and any 2 investigations positive, and even in the biopsy or bilateral hilar lymphadenopathy is absent, you'll say it's a probable ocular sarcoidosis. Now, the same thing is depicted in a pictorial form, and we'll go through it again. So you have 3 ocular signs and 2 investigations, it is probable ocular sarcoidosis. 2 ocular signs, bilateral hilar lymphadenopathy, it is presumed. And for definitive, you have to have ocular sign and histopathology positive. Now, let's look at these investigations in a little bit more detail. So these include tissue biopsy, ocular imaging including FFA, ICG and OCT. You can do systemic imaging, chest X-ray, CT chest, PET and gallium-67 scintigraphy. And other tests like Manto, serum angiotensin converting enzyme and serum lysozyme. Earlier, we have discussed that sarcoidosis is a multi-system disorder which can involve any part of the body. So depending on the site of inflammation and its accessibility, you can take tissue samples either from lung, lymph node or the skin. And as far as the eye is concerned, you can take samples from conjunctiva, lacrimal gland or the orbital tissue. If the site of inflammation is not very obvious clinically, you can use imaging modalities to decide the site of the biopsy. So what you're looking for in histopathology is these non-caseating granulomas, as you can see here. So they are composed of epithelioid cells, multinucleated giant cells surrounded by lymphocytes. Coming to the ocular imaging in ocular sarcoidosis, the role of fundus fluorescent angiography is to confirm or assess vasculitis or choroiditis activity and how it's responding to treatment, and also to identify neovascular complications like NVD, NVE, and CNV. Now let's look at this fundus fluorescent angiography of ocular sarcoidosis. So before you actually interpret the FFA, you need to examine the patient clinically or look at the color fundus photograph to identify the important features. For example, in this right eye color fundus photograph, you can make out that the disc is edematous. You can also see these multiple pale subretinal lesions suggestive of choroiditis. And see what happens in the AV phase, that is disc hyperfluorescence. And corresponding to these lesions, you see hypofluorescent patches. In the late phases, they turn hyper. So this is very typical of choroiditis. It's the same eye after treatment. You can see that the lesions have disappeared, the disc edema has resolved, and what you're seeing is just pigmentary changes. And correspondingly in the FFA, what you see is blocked fluorescence from the pigment and window defect due to the RPE changes. Similarly, in this case of active vasculitis, you can see the vascular leakage here. and after treatment, it is resolved. This is yet another case of ocular sarcoidosis with optic nerve granuloma and nodular periphlebitis, which is more obvious in the fundus fluorescent angiography. Like I said, the other area where FFA is useful is in identifying and following up neovascular complications of sarcoidosis. So this is the right and left eye of the same patient with ocular sarcoidosis. In the right eye, you can see this network of fine vessels on the disc, suggestive of NVD. And the left eye, you can see this juxtapapillary thickening with fluid and hemorrhage, suggestive of a juxtapapillary choroidal neovascular membrane. Let's look at the FFA of the right eye. You can see that there is disc hyperfluorescence, which increases throughout the FFA. You also see the vascular leakage and the non-perfusion areas here. Okay, so not only does it help us to identify the neovascular complication, it also helps us to decide which area of the retina needs to be lasered. The same patient in the left eye, you can see the early hyperfluorescence corresponding to CNVM increasing in the late phases. Coming to the usefulness of ICG. ICG images the choroid better. So in those cases where the lesions are not very clear clinically, it helps to identify it much better than the fundus fluorescent angiography here. So OCT in ocular sarcoidosis is very useful in diagnosing and assessing response to treatment in cystoid macular edema, choroidal neovascular membrane, and even in sarcoid granuloma. For example, take this patient. This patient actually had a very depigmented fundus, a lot of RP alteration. It was very difficult to see whether they are developing new granulomas. And when she presented with sudden onset of blurred vision, and we did a OCT, you could see this choroidal granuloma here, which after treatment has disappeared. Similarly, this is our earlier patient who had choroidal neovascular membrane, which was juxtapapillary. You can see that before treatment, there is retinal edema, there is a choroidal neovascular membrane with the SRF, which after treatment, the retinal edema has decreased and the SRF has resolved. Coming to the systemic imaging modalities for sarcoidosis, we know that the lung is involved in 90% of the patients, and the most easily available imaging modality is chest X-ray. So the chest X-ray changes in sarcoidosis has been classified into 4 stages. In stage 1, you get mediastinal lymphadenopathy or hilar lymphadenopathy, but the lung itself is not affected. In stage 2, you have mediastinal lymphadenopathy and pulmonary infiltrates. In stage 3, the hilar lymphadenopathy resolves, leaving behind the pulmonary infiltrates. And stage 4, you get pulmonary fibrosis, and there is no hilar lymphadenopathy. So what about the role of CT chest? Definitely CT chest has better resolution. It picks up more findings compared to chest X-ray, but it should not be used for routine screening in sarcoidosis because of the increased amount of radiation. You will prefer to use CT chest if you have a normal X-ray and you suspect sarcoidosis strongly, or you have trouble differentiating sarcoidosis from tuberculosis. So this is the CT chest in sarcoidosis showing hilar lymphadenopathy. Now let's look at some of the differences between sarcoidosis and tuberculosis, which can be seen better in a CT chest. So bilateral hilar lymphadenopathy and fissural subfissural nodules are more common in sarcoid as compared to tuberculosis, whereas apical fibrosis is more common in tuberculosis. Coming to the other 2 imaging modalities, which can be used for a systemic workup, you have the gallium scan, where you inject gallium-67 isotope, and 48 to 72 hours later, you use a gamma camera for scanning for uptake. So the usefulness of this technique is that you see abnormal uptake in areas of inflammation, which may not be obvious clinically, and you can identify potential biopsy sites. So there are 2 signs which are associated with gallium scan and which you should be familiar with. First is the panda sign, where you get increased uptake in the lacrimal gland and in the parotid gland, and this picture is supposed to look like a giant panda's face. The second is the lambda sign, like that, because of uptake in the parahilar, infrahilar bronchopulmonary nodes and the right paratracheal mediastinal lymph node. So the next imaging modality, which can be used for a systemic workup, is fluorine 18-fluorodeoxyglucose PET scanning. Now this is more of a functional imaging in that it is based on the increased glucose metabolism. Obviously, if you have more inflammation, you will have more glucose uptake in that area. So it helps to assess activity and also identify potential site for biopsy. Now let's look at the other tests which can be done in sarcoidosis. We all know that manto will be negative in sarcoidosis due to what is called a phenomenon called cutaneous energy. That's because all the helper T cells are pulled towards the granuloma, and you get a relative depletion of the helper T cells in the peripheral circulation, resulting in a negative manto or a negative interferon gamma assay release test. What about the role of serum angiotensin converting enzyme, which is a commonly done test in sarcoidosis? Now, this is an enzyme which is secreted by the macrophages in the sarcoid granuloma. Actually, it reflects the load of granuloma in the body. But when you interpret this test, what you need to remember is that the values depend on the age. So young patients, those who are less than 21 years, generally tend to have a higher normal value, and you should not interpret it as being pathological. So the normal values can vary, but it's usually around 52 to 55 units per liter, and it is increased in 60 to 90% of cases of active sarcoidosis. But the values have poor correlation to the disease activity in the eye. So let's look at some of the situations where you can get false positive reactions and false negative reaction. So as you can see from the list here, many of the other granulomatous uveitis like tuberculosis, leprosy, and histoplasmosis can result in a false positive serum ACE. Also, diabetes, chronic pulmonary disease, rheumatoid arthritis, and primary biliary cirrhosis can also give rise to false positive tests. You can get a false negative test in the early stage of the disease, or a disease that is limited to one part of the body, say it's limited only to the eye, or if you're using angiotensin converting enzyme inhibitors, or the patient is immunosuppressed for some reason, either with steroids or immunosuppressants, or you're given chemoradiation. The serum lysozyme is yet another enzyme which is secreted by the epithelioid cells in the granuloma. Again, like the serum angiotensin converting enzyme, its values are age dependent, but in the opposite direction. So it is normally increased in age above 60 years. Its sensitivity is around 60% and specificity is around 70%. So if you have a patient, say, who is on ACE inhibitors, you can go for serum lysozyme instead. Now, the presence of lymphopenia, it's a test which you can do very readily because it's very easily done. So if you have a lymphocyte count less than 1,000 cells per microliter, it is suggestive of sarcoidosis. But the only problem is this is not a very specific test. There are a number of other situations where you can get a lymphopenia. So coming to the treatment of sarcoidosis, the agents or the group of medicines which are available for its treatment are steroids, either topical, local, or systemic, conventional immunosuppressives like methotrexate, mycophenolate, and azathioprine, and the newer biologicals. Now, the treatment of sarcoidosis is dependent on three factors. One is where the maximum inflammation is, or the anatomical diagnosis, whether it's limited to the eye or whether there's a systemic involvement as well, and also the severity. So the first line of treatment for sarcoidosis is steroid. Like I said, which type of steroid will depend on the anatomical diagnosis. We said that mostly you have anterior uveitis, and this can be managed with topical steroids. You need a strong steroid like Predfort, dexamethasone, and sometimes diphenhydramine and cycloplegics. The local steroids may be posterior subtenon tricot, intravitreal triamcinolone, or a steroid implant like Ozurdex implant. So local steroid therapy is used when you have inflammation in the posterior segment or a cystoid macular edema. Now, you may use it as a standalone therapy when only one eye is involved and there is no systemic involvement. Or you can use it when there is a non-compliance to systemic medicines or intolerance or side effects from systemic medicine. You can even use it to supplement the systemic medication. Coming to systemic steroids, again, the indication is practically same as for deposteroids. So you will use it to treat inflammation in the posterior segment, either intermediate uveitis, posterior, or pan uveitis. Any uveitis with systemic involvement in sarcoidosis, you should use systemic steroids for obvious reasons. And the dose you will begin with is 1 to 1.5 milligram per kilogram body weight. And it should be tapered slowly. If you have vision-threatening lesions, say like an optic nerve granuloma or a very severe inflammation or very diffuse vasculitis, you can even go for intravenous steroid therapy to begin with. So when will we move on to conventional immunosuppression in sarcoidosis? Say you started high-dose oral steroids and you're not able to control the uveitis, then you will go for immunosuppression. The other indication is, say you started steroid, you had some control of inflammation, but you are not able to taper steroids to below 7.5 milligram per day, or the patient is developing intolerance or severe side effects from steroids, or you have recurrent inflammation, then you should use conventional immunosuppressants. So if you cannot control the inflammation even after adding conventional immunosuppressives, or you have intolerance or side effects from conventional immunosuppressives, you can move on to the newer biologicals like adalimumab or infliximab. The only point of caution is these agents can actually cause sarcoid-like granulomatous inflammation, including uveitis. So I would like to acknowledge my colleague, Dr. Shubhan's contribution to preparing this session. So in this session, we have covered the latest diagnostic criteria, the various investigative modalities, and the treatment of ocular sarcoidosis. I hope you have found this useful. Thank you.